So thanks, folks, for joining. And this is chapter 17 of our Bouncebacks Critical Care book. And we are really honored to have several of the chapter authors, as well as other folks that are joining us also, which is really fantastic. And as we are going through this, we're now more than halfway through. We're into the drugs and delirium section. And we're really honored, especially to have Sean Nordt here with us, who everybody knows and loves, and Sean being both EM and toxicology. And of course, there's so much other good wisdom on the line. I'll introduce that in just half a second. But first, I want to just make everyone aware that there are no conflicts from any of the speakers. And this is our disclosure form with the objectives. And I'll leave that up there for a second. For folks that have registered and looking for their CME, here is the code that you can click on to obtain that CME, and I'll put that up at the very end also. Anyone that's interested in signing up for subsequent Bouncebacks critical care book clubs, you can go to the website, just EM, like emergency medicine, so embouncebacks.com, and that'll have the current and usually the next 1 or 2 months worth of book clubs on there. So the case today, actually, so let me first go by introducing our speakers here. We have Emmanuel Akpan. He is one of the residents at Adena in psychiatry. He's a PGY2, and he's going to be sharing his wisdom in psychiatry, specifically with something that all of us emergency physicians think about a lot every time we are ordering tests for patients with psychiatric conditions that always seem to come back normal. However, he's going to shed a little bit of light on maybe a different way that we can sort of think about obtaining data that actually could be helpful. Colin Kaide, who I've worked with for years at the Ohio State University, and he's associate professor of emergency medicine. Also, Kay Moody, who is not only the founder of EM Docs, but also a adjunct clinical faculty at Pacific Northwest University College of Osteopathic Medicine. And then Sean Nordt, that I introduced initially, and can really, Sean, I don't think all your titles only make you seem less. You're so much even without them, but there are very many initials after your name. So, and I just have to say, I know Sean doesn't know I'm going to say this, but literally this feels like one of the most confusing topics, toxicology to most people. And not only because sometimes there's a solo ingestion, but usually there's multiple ingestions. And Sean, you just have such a way of explaining a complex topic in a way that folks can understand, super respectful, not only for your knowledge, but also the way that you're able to educate folks and teach about these things. So that's fantastic. The case that we have today is a case of a 48-year-old man with a beta blocker overdose. And I said it was chapter 17. I think that's actually 17. It's not 16 as on the slide. So the story starts with him and his own story. He's a divorced father of 3 grown children, recently started a new antidepressant medication. He'd worked at a convenience store, then a supermarket, most recently for a lawn service company, but due to monetary and transportation issues, he has struggled to obtain his medications and recently got medicines at a low-income clinic. He didn't have perfect adherence to his medications, and oftentimes at the end of the month, he is left with still some additional medications in the bottles in the back of the medicine cabinet. So at some point, maybe we can even sort of go into some of that medication diversion sort of thing also, because it's not just narcotics. There can be other medications that happens with also. But at any rate, he learns of a overdose of his 22-year-old son. His feelings of sadness escalate, and he presents the emergency department with suicidal ideation and is admitted to a psychiatric hospital for 6 days. He's determined to be safe for discharge, and then he is discharged. So before we even go into the actual critical care aspect of what will turn out to be, as we see here, a beta blocker overdose, I want to just very briefly, and I'm going to sort of skip to ahead just for half a second here, this consideration of this shotgun lab testing, because we do a lot of that, of course, and I've learned not to fight this, but CBC, electrolytes, a urine drug screen, and then, okay, maybe I get the serum stuff a little bit, but with patients that are coming in for non-overdose type of suicidal ideation, it seems hard to imagine how any of these things specifically could help us. And here's a list of all kinds of medical problems that can actually present as psychiatric illnesses. And I'm sure all of us that have been practicing emergency medicine for all this time have had patients where, and I sort of tell this sort of joking sort of way, when the nurse says to me, Dr. Weinstock, this patient is really anxious or just anxious. And I say back after the evaluation, I agree with you that they're anxious, but they're anxious because they're dying because they have a saddle embolus, right? So a lot of things can cause shortness of breath or feelings of anxiety when it's a premorbid state, right? As well as a lot of other things that we have on this list here. And some alarm symptoms that don't typically get confused. I mean, anxiety certainly could get confused, but things like, unilateral numbness or weakness or jaundice or some of those sort of things would be a little bit more concerning to us as far as bumping stuff up, as well as, importantly, patients who don't have a psychiatric history. So these are just a couple of screenshots from one of the articles that Dr. Manuel is going to detail for us in just a second here. But interestingly, these articles or these tables here are, I think, pretty interesting because, I mean, it's pretty voluminous, the number of things that can be present here. I just sort of highlighted the battle sign of raccoon eyes, but what happens to people who have psychiatric illnesses, and sometimes those patients don't have great housing situations, and maybe are homeless, and they would be prone to some of these other types of things that could happen. So, Dr. Manuel, can you detail for us? We have two studies here that I just sort of want to start with, just 60 or 90 seconds each. Both of these are by Reeves, but pretty interesting findings in these studies.
Yeah, definitely. Thanks for having me on again, Dr. Weinstock.
Yes.
Yeah, the article by Reeves and Company is really interesting because it explores a lot of the different factors where clinicians sometimes can misinterpret, acute altered mental status and attribute it to a pre-existing psychiatric condition. And a lot of those folks kind of go through the cracks where they should be treated for delirium. So in the first study, it takes a sample size of elderly patients, so 65 and up, from the VA setting to the public community hospital, and they had approximately 1,300 total. They looked at retrospective cases and took 20 of those cases to evaluate a little bit more. And what they found is that there was a 2.3% misdiagnosis rate in those patients who should have been treated for delirium in the elderly population, but were kind of shunted off into a psychiatric facility. And there are various critical factors that they looked at. They looked at vital signs, past medical history, past surgical history, psychiatric history, and physical examination. So there were a lot of things and important clues to distill and have it at the very end of the first article. Just kind of gives some methods of how we as clinicians can kind of tune our brains a little bit more towards those medical etiologies, and not just kind of pushing it to the wayside, especially with a patient who has prior psychiatric history. And the second article in that series does something similar, as they take patients, but younger age range, so the 18 to 64-year-old range. And yes, as you pulled up, 22.8% of about the 1,300 patients who were evaluated had a misdiagnosis and admitted to the psych ward with a pre-existing medical condition. So with some of their recommendations and some of their criticisms as a whole within the system, is how are we as clinicians doing in terms of really systematically looking at each patient, right? When we're looking at their, their cognitive assessment, which is the major glare that seems like a lot within the emergency department that some docs aren't doing as much, whether it's administering a CAM assessment or a mini mental, or even the slums. There's a lack there where some of those patients are able to kind of escape through the cracks. And in the inpatient psychiatric setting, of course, you can't have things to correct for medical etiologies, right? No IV bags are available or oxygen because sometimes they can be a ligature risk. So that is basically a summation of those Reeves and Company two articles. And then they at the very end, they also gave some recommendations for the American College of Emergency Physicians protocols that sometimes what we have to do is walk before we run, meaning that we have to look at the physical examination and cognitive evaluation as the guiding light before we're ordering blindly a battery of labs or getting a neurocognitive evaluation or doing neuroimaging or even suicide risk assessments. So it's really taking that time, whether it's in chart review or physical exam, to really get a holistic view of the patient.
Well, thanks. That was an excellent summary of that. And so, KK, let me bring you in here, and then we'll get straight into our case here. What does ASAP have to say about these psychiatric labs, this routine testing that we do before people are evaluated by mental health for things like suicidal ideation?
Yeah, so thank you so much, Manny. That was really amazing, and I agree with everything you said. And ASAP, interesting enough, put out clinical guidelines both in 2006 and 2017 that are in alignment with what you're saying. Is that we don't necessarily need to routinely do laboratories, just blindly shotgun approach labs on patients that are presenting to the emergency department for psychiatric emergencies if we know that they are having psychiatric emergencies. And that's where our clinical acumen comes in. Is this truly a psychiatric emergency? We can't just say, oh, they're just anxious. We have to do the full assessment of their clinical history. Have they had psychiatric issues before? Even if they have, we still have to do a very thorough history of present illness and a physical exam, and really listen to all of our senses when we are in the room with the patients. But ASAP, according to their clinical policy, critical issues in the diagnosis and management of adult psychiatric patients in the emergency department, they have a whole section where they took the ASAP clinical policy on whether or not we do shotgun approach, just routine labs on every adult awake, primarily psychiatric patient in 2006. And the answer at that time was no. You, just like we said, they depend on their history and their physical exam, and that they should not necessarily be performed routinely, and that they generally delay care, and that they don't really usually add anything in the disposition or management of the patients. So then in 2017, they took another good look at this, and they did a deep dive, and they brought in another couple of articles. One was from Janiak and Arterberry, and they looked at 502 consecutive patients in a large academic center. And they found that, with only one exception, laboratory tests obtained by the psychiatric services would not have changed the management. And then another article was from Parmore et al. 598 patients were looked at presenting to the emergency department with psychiatric emergencies. They did do labs at that time. Only 44% of the patients got labs, 155 patients. And with only one exception, the laboratory values did not lead to any change in the disposition. So they were both in agreement, and in agreement with what you were saying, Dr. Bacco.
Yeah, so KK, thank you so much for that. And what can we take away? This is sort of just my own sort of conclusions from this, and I'll call myself out just a little bit as a guy that always complains about the psychiatric labs. Is like, maybe I could be doing a better job with some of those neuro sort of assessments, either a neuro exam or getting a better history or exam. But times that we want to be especially cautious, if there's a new diagnosis, especially, new diagnosis over the age of 40 or 50, it's sort of unusual to just happen to develop schizophrenia when you're 60 years old, right? Elderly patients obviously can have a lot higher risk of something else being confused, a medical problem, as a psychiatric illness. Some of those warning signs, we talked about those before, and then just again doing that pretty good history and physical. So thanks so much for that, both of you guys. It is time to now delve into our case. There's the EMS now brings this patient back. So what happens with his story? So he goes home after 6 days in the inpatient psychiatric unit, and then what happens is he decides, with all those pills that are left in the back of his cabinet, and this is less than 24 hours after being discharged, he is overwhelmed by feelings of hopelessness. He obtains his partially used blood pressure medicines and impulsively ingests the remaining tablets. Sits down on the tile floor, staring straight ahead. 90 minutes later, he starts feeling dizzy and short of breath, and he panics and he goes to the bedroom and dials 911. So here's what we have as far as the physician note. This is at 8:48 in the morning. Chief complaint, suicidal and ingestion. They document ingestion of 2.4 grams of propranolol, which are about 40 long-acting tablets, 60 milligrams each. And this was 90 minutes prior to arrival. His symptoms are dizziness and shortness of breath. You can see his vital signs. He's a little bit bradycardic. I mean, if it wouldn't have been a propranolol ingestion, I don't think any of us are incredibly concerned about a heart rate of 55. But his blood pressure, also just a little soft, maybe not too horrible, and the SAT is okay. He's mildly diaphoretic. It's documented he's bradycardic. And they had looked at the past records there. So, KK, just like in like a 1 or 2 sentence sort of summary here, how often do we see beta blocker overdoses? I mean, I'm guessing acetaminophen and salicylates, and there's a lot of other things that people would ingest before they ingest beta blockers.
Surprisingly, more frequently than we might think. So in 2015, there was approximately 25,000 poison control calls regarding beta blocker overdoses. Only about 10,500 of those were single ingestions. So we always have to think about co-ingestions because they're so common.
And so, Sean, that takes us right to you. You have been very patient, and I remember many, many years ago, it might have been a conference we did together. Maybe I just heard you speak, but thinking about other ingestions, right? I guess 2 parts to this question. How commonly are ingestions multiple substances? And when we know that they took propranolol, what other things do we want to consider that they might have taken?
Well, thanks for having Mike, and it's great to be here with everybody.
Yes.
So let me just start with this case. This guy worries me, and I'll tell you why. Because very often we'll get these people who bounce back. No pun intended, Michael, for your book, right? But people
Exactly.
like, oh, they're looking for a turkey sandwich. They're just right. They were already cleared they were just seen by psych. He's tried to kill himself before by hanging, right? So he's at least got a previous attempt of a very serious attempt, and he's got hypertension. So you can say, yeah, this is a little bit of a soft blood pressure, but he usually is probably minimally compliant, usually probably 160, 170, 180 systolic. So I'm very worried out the door. People who really want to kill themselves, and if there's one thing I can instill on everybody listening, people who want to kill themselves, and if they've done their homework, hide the most dangerous medications. So they might come in and just have an ibuprofen bottle, right, or something like that, and lull you and me into a sense of security. So you have to assume that this is a polydrug poisoning. Yes, it's already shaping up to look like a beta blocker poisoning, but this absolutely could be a polydrug poisoning, because that is not uncommon with people who are serious about killing themselves.
So a little follow-up question to that, and I know the answer to it already, but certainly you're also checking acetaminophen and salicylate levels on this patient.
Absolutely. So, and I think if you read the chapter, there's so tox is really down to good physical exam, right? And a handful of labs. All I really need is electrolytes. I really don't need a CBC. We'll often get it, unless I was thinking for some reason we'd call hemolysis or something like that, or a rattlesnake envenomation. But a VBG is very helpful to give me a serum pH to see what's going on there, and an EKG. So that's really all I need. I can figure out most of it based on physical examination and with those handful of labs. Now, you're right, Michael, acetaminophen, because if they come in and their right upper quadrant hurts and they're vomiting and all this other stuff, well, more likely than not, they took it several days ago. But we want to capture them early and institute the N-acetylcysteine. And if there's any hint that there could have been an acetaminophen ingestion, right? Like, let's say he said, oh, I think I took some Tylenol, and it's getting close to the 6 to 8 hour mark, just give him a dose of N-acetylcysteine. Little downside. Salicylate, and Michael, you and I are around long enough. that we used to see this much more commonly. It is very subtle. And when people say, well, I should be able to tell because there'll be some, just like we heard our excellent colleague talk about, delirium is completely different than dementia, right? And I think people blend the two in, like delirium is a completely different state of waxing, waning mental status. Salicylate poisoning, particularly early on, can be very subtle. And if it gets away from you, they are going to die. So yes, acetaminophen, salicylate, and those other labs I mentioned are what I routinely will get in every intentional poisoning.
And I very much want to differentiate what we were talking about earlier as far as the ACEP statement was not for a overdose. That was for patients who profess suicidal ideation or some sort of psychiatric type of thing. This is a very different beast that we're talking about here specifically. We know this person took at least one thing propranolol and maybe other things too. So Colin Kaide, let me bring you in here. Specifically, what studies are you ordering on this patient?
I'd say the big money things, as Sean mentioned, EKG, maybe Chem7 if I'm interested in looking at an NIN gap. Certainly acetaminophen and salicylate. For me, I think I've been more traditionally doing the acetaminophen levels more so than the salicylate. If I really don't have a person who I think is sick at all, and I'm doing it more for a screening situation. Probably LFTs and maybe the VBG is very helpful in a lot of these patients. EKG is very useful to me in looking at QRS and QT intervals and tachycardia and maybe some other clues like the R prime in AVR. I'm old enough to remember that and actually have seen that in tricyclic antidepressant overdoses, but. I start with the basic stuff, and I just want to make sure I can get an idea, especially if there's an acidosis or something that I can dig down a little deeper on.
So before we go to our next question, just a little follow up on that, both for Colin and anybody else, Sean or anyone else that wants to join in on the answer to this. But certainly the heart rate will be something we can determine just from the monitor. The EKG can look for other things, such as you said, Colin, with like TCA, toxicity, et cetera. What other things specifically on the EKG? Because, we always get it. And I sort of feel like a lot of times it's like we get it, it looks okay, or maybe there's something. But what are we specifically looking for on that EKG as far as some other substance that would show up there with a co-ingestion?
Well, I think that there's a lot of things, and the EKG is such for a cheap test, is so excellent. So with this one, let's just go with this one. We're looking for blocks. Right? So this does not, actually, this is unique because propranolol actually can cause an intraventricular conduction delay. So it can act like a cyclic antidepressant. Actually, the better term is a sodium channel blocker. So anytime you see a wide QRS, particularly in toxicology, or I should say, just give bicarb. Right? Don't presume that it's like pre-existing, right? Because you don't know. If it narrows, you get an answer. If it doesn't narrow, maybe it's not. So the things we're looking for are blocks. So we're really looking for second-degree blocks and up to complete heart block in this person. If it's digoxin, you might see some things. So remember we're bringing up all this stuff that we've learned so many years ago, like the Dali mustache. That is a digitalis effect. That does not mean they're toxic, but that might clue you in. The thing that would clue you in more is a widened QRS or peak T, something that suggests, particularly an acute ingestion of hyperkalemia. If this was a toxic alcohol, so ethylene glycol, we cannot get the levels. I'm a former poison center director. I couldn't get them for a week. But if they have a shortened QT, because one of the things that we look as a surrogate marker is hypocalcemia. So we do want to look at the QT. Now, QTC prolongation or torsade is almost never seen with acute poisonings, which is actually a good thing for us. That's much more with chronic stuff. But you want to look like you own that whole EKG. And what Colin had said, appropriately so, is you want to see that's actually some right heart changes that you're seeing, right? When you're seeing the AV, the tall R and AVR and things like that, very suggestive of a cyclic antidepressant. Cyclic antidepressant, sodium channel blockade drugs, they get sick and they get sick really quick. So if you see that subtle terminal 40 millisecond, you better be ready. I have bicarb stacked at the bedside because what happens very often, and propranolol can do this, it can cause seizures. Once they have a seizure, their pH drops and their QRS widens and they go into VT, and it happens just as quick as I said it right there. It happens that quick.
So Sean, let me ask you this, because Colin talked about the studies that he's going to get, and then I'll actually throw this out to Sean, and then Colin, I'd like to have your thoughts on both of these also. That certainly seems like the other thing with the EKG. Say we do have a propranolol overdose, there's some bradycardia on the monitor, but now we see that the patient has some type of second or maybe even third degree block that might also sort of prompt us for more emergent management or bumping our intervention up a little more quickly and a little more intensively, I would imagine. But what initial treatment with this guy who, yeah, I agree, Sean, probably his blood pressure is 160 normally. Now it's 104. He's a little bit symptomatic. I mean, he's certainly diaphoretic, you know. So what would you first start with, Sean? I'd like to know that. And then Colin, you actually were involved with this specific case, correct? So
Yes.
we're going to get to that in just half a second. So don't like I guess ruin the surprise on it. But you know, what would you start with right now, Sean, with this specific patient? And then I want to get to Andrew Coons had a question in the chat. So Sean, why don't you just start with that initial question?
So first things I'm going to do, because he's relatively stable, right? But I'm going to make sure he's in a room where I can see him, right? He's not tucked down. You know, I work at 2 different hospitals, and I have these kind of corner pocket death rooms where like I never want sick people there because they're hidden away. No one goes and sees them, right? Until like someone realizes, oh gosh, they're unresponsive. So I'm going to want them on a monitor, right? And I'm going to say to the nurses, right? Hey, if you go on break, you got to let the person who's relieving you, like, this is what we're looking for. I'm going to speak to the pharmacy. One thing I'll bring up now, because I might forget, but you probably all know this, is glucagon is no longer being manufactured as far as the emergency IM dose for hypoglycemia. So that is no longer available. And because of that, glucagon is really not found much in any hospitals anymore. So your pharmacist might have to start rallying around, calling local hospitals, other things, if glucagon is going to be there, right? If you are thinking of whole bowel irrigation, right, you might deplete all their go lightly. So I would pull the pharmacist in very early and say, hey, these are what I anticipate. I'm going to need lots of calcium potentially. I'm going to need lots of glucagon potentially. I'm going to need a lot of epinephrine as far as an infusion. I might need sodium bicarb, because the way that I always teach my residents and students and I practice is like, I always think, what is going to happen and what am I going to do when it happens? And I look for reversible causes. So if I have that stack of bicarb there and they wind out their cure, I'm not scrambling. I'm not going to the Pyxis. Oh, the person's not registered. They're not this, right? All this stuff. So I like to have that. And I say, hey, and then I tell my team, including the nurses, if this is what I'm worried about, and if you see this guy's blood pressure go, or whatever, heart rate go down to 30, even if it's for a minute or two, you got to grab me, because I don't want to be pushing on the chest. And I'd be absolutely want to hear what, because Colin was there, right? Like what he did. And of course, there's multiple ways to approach this, right? Just because I'm saying it isn't the only way. Of course, there's lots of different ways to approach it.
So let me nail you down just a little bit on this. So it's a good idea. We got the pharmacist called. Everyone sort of knows this potentially could be a 4-alarm fire. But what are you specifically doing? You got this guy, and I haven't really told you more so than just the evaluation. We knew it took 2.4 grams of propranolol. Those are his vital signs. What are you specifically ordering as far as interventions?
Okay, absolutely. I'm giving this guy activated charcoal, hands down. Activated
Okay.
charcoal, whole bowel irrigation. There is nothing, right? I'll be prepared to intubate. I may or may not. It depends. I mean, I'm not at the bedside. I'll have to defer to Colin. If I think, hey, this guy's getting sick, I might just go ahead and intubate him, because if he did take what he did, right, there's a good chance he could get really sick and potentially die. And once that gets absorbed, we can't get it out of the system. Right, propranolol is not dialysable. Right, he's going to be, so what do we worry about? He's going to be too hypotensive for dialysis anyway. ECMO, do I want ECMO to be my deferral? Right, so I'm going to try to decontaminate him as aggressively as possible. And I like activated charcoal, but I rarely use it. But this would be one of the few choices. And I use this, and Michael, you probably heard me, I use it like blood in the water, right? When I see charcoal coming out the other end, maybe it's binding it up, but I'm at least saying, hey, I'm moving stuff through the GI tract. So that's really how I use it. Once I see charcoal coming out the other end, yes, maybe it's going to bind up the stuff, but it's not going to bind up 40 grams or whatever this, huge dose is. But at least hopefully it'll bind up some as these sustained tablets break down. Because remember, for drug to be absorbed, it's got to be soluble. It's got to dissolve. So as it dissolves, I'm using the charcoal to bind that, but I'm being very aggressive with whole bowel irrigation to get this stuff out, ideally intact, before it breaks down and gets absorbed.
So I think hopefully, Andrew, we answered that question. Sean did. And if not, put something else in the chat. We'll get to the next question in just a second. But before that, Colin, what types of overdoses will patients come in and look good initially and then decompensate?
Well, I can tell you for sure, this guy was that example.
Right.
I just give you just a couple of things that were not necessarily in the full narrative. His friend came in with him, and the guy himself looked anxious. And I looked at his friend, and his friend goes, "Oh, he absolutely took it. He absolutely took this. I have absolutely no doubt." And he was one of those who looked great initially, despite the description. He looked pretty good, and then he fell off very, very quickly. I would think about this kind of presentation maybe in sustained release preparations of things. Tricyclics for sure from back in the day. They looked fine, then they didn't. And then they tried to die on you very hard. Certainly calcium channel blockers, valproic acid. I'd like to hear Sean's thought on this, but I think maybe ethylene glycol, they can look intoxicated at first and look okay until they get enough of the toxic metabolite, and then they can fall off fairly quickly. Iron, but with its particular pattern, I would say salicylate, especially if you have a Bezor formation, and then when the Bezor breaks down, the salicylate levels may jump quickly. Those are the ones that I like to think about when I think about looks okay and then doesn't.
Yeah, maybe even acetaminophen. Maybe you said that in your list, but I would think that like sort of early in the course of things might even look pretty good, obviously, before they decompensate. And Sean, I know you're talking like, yeah, 6 or 8 hours, reach for the N-acetylcysteine. So let's do this just to keep things moving, and we can come back to this. We certainly will. So what happened with this patient here? Okay, hold on a sec there. So what happened with this patient? And I would just shout out real quick to Dr. Emmanuel and some of the psychiatry residents from the program at Adena with his really nice publication, Psychiatric Manifestations of Medical Disease. So, okay. Anyway, we are now getting to our decision point A. And we've talked about some of those things. This was the initial presentation of the patient and that we talked about a second ago. So what actually happened with this patient? So this was documented that the differential included beta blocker overdose, of course, or co-ingestion, possibly acetaminophen or salicylates or other household poisons. And just as Colin said, ordered labs, CBC, chem sub, and LFTs, lipase, EKG, and they actually did give, as Sean recommended here, activated charcoal 100 grams. The patient had presented, I believe it was 8:28 a.m., I'm pretty sure. And here it is less than an hour and a half later. Now all of a sudden his heart rate is 44, respiratory rate is 26. He's hypotensive and a little bit hypoxemic too. They document just a little bit, so about an hour and a half after he presented, 9:59. Patient on the moderator card is worse and caused the alarm bells to ring. He's becoming more confused. Blood pressure is low. They gave normal saline, some atropine, which didn't really do a whole lot. And they did decide to intubate the patient at this time, which they did without any difficulty. He's given a second bolus of fluid. On epinephrine infusion is started at 4 mics per minute. And then he also got glucagon. So in just a second, we'll sort of go to the chat there and why glucagon isn't available. But before we do that, let's just sort of dig right in here, as well as he got 3 grams of calcium, gluconate, 3 grams is given IV. So Colin, why don't we jump right in here, a little bit of self-analysis. This wasn't a confusing story when he walked in. You knew this guy took something bad. You knew things had a very high probability of going south fast. But do you feel like what he got initially was enough, sort of looking at it in retrospect, or did we perhaps wait too long before he got those medications?
I think there were a couple of issues here. I'll add one piece of color to this story because I thought it was quite interesting. We did give this guy the activated charcoal, and when we pushed the glucagon, you can imagine what happened to him. I have never seen a nurse move like they were in the Matrix before, but as this guy sat up from almost completely flat and vomited a cloud of black stuff all over the wall full of pills. And I've never seen a nurse move that fast in my life. And it was almost like in slow motion. She just dodged out of the way of this blast from him. So he may have actually done a little decontamination himself. And I think in retrospect, cognitively, we knew what we needed to do. And the process of getting it all done in that circumstance, if I had done this over again, I would have used the advice I sometimes give to the residents: stay in the room and bug the hell out of everybody until they get exactly what you need. We were a little slow on getting the glucagon in, and there was some hemming and hawing with regard to pharmacy trying to get insulin for us in large doses. I actually, in this actual case, I have to say our ER pharmacists are amazing in our institution. But we had one who was relatively new, and I actually called to get one of the more experienced ones to come over a little later. And I think if I had done that earlier, the processes would have happened a lot more smoothly. And I think we were behind a little bit on this one.
Yeah. Well, Colin, I wanted to really emphasize a point that you made, and this is something that I say a lot, and people probably think I'm sort of a jerk when I say it. But in the Midwest here, Sean, maybe it's not quite the same thing in Los Angeles or maybe in New York, but in the Midwest, we're very nice. We're very nice to each other. And, well, they're the pharmacists and they're new, but they're nice and we're nice. And, I mean, literally, this is the time to just not think about anybody's feelings and just to do what's best for the patient. So, Colin, the fact that you called and had the more experienced pharmacist come down, I've done that frequently with patients. Like there's a nurse who's doing their best, struggling to get IVs and all the different things that need to be done. And I say, you know what? I'm going to go talk to the charge nurse and have them come in and get another 1 or 2 bodies in here. And 4 people can definitely do things faster than 1 person can. So I would just say this is not the time to be the nice person. This is the time to really advocate for the patient. So, Sean, we talk to Colin. And I mean, look, you say maybe we'd have done these things differently, but it sounds like you did really a pretty good job. I mean, you gave this patient a bunch of medicines and maybe it could have done a little bit quicker. So I'm not saying it should or shouldn't have been, but I'm just saying that, despite what you did, this patient started decompensating. So Sean, where do we go from here management wise, considering what the patient has already received and where they're at intubated and bradycardic and hypotensive?
Yeah, I think Colin's being too tough on himself. I think, the reality is, I mean, I've had patients, I've used this example, who have gone out, right, been cleared from psych and go out and take a handful of stuff in the waiting room. And by the time they get re-registered here, it's like 45 minutes, right? So to think that stuff, right? So I think you did a great job doing this. But this guy, so I just want to mention this too so I don't forget. Let's say this guy was still asymptomatic or relatively asymptomatic at 6 hours. Do not discharge him. Like if you want to keep him in the ED, you got to keep him for 12 hours, right? If he's asymptomatic at 12 hours, he probably didn't take it. 6 hours though isn't enough. But this guy kind of declared himself a little bit earlier, right? So he did that. So I think what I'm doing, I like epinephrine, right? Glucagon I will usually give, but glucagon kind of is like calcium. It's very transient, right? And then like Colin had, the guy vomited, right? That should not be a reason not to give it, but give ondansetron or give some antiemetic while you're give it. And, you could even give like 8 milligrams if you want of ondansetron to just kind of pre-treat them. Or say, you know what, this guy's heading south. I'm just going to intubate him, as they appropriately did, right? They intubated early, which I think is good. And then, so I just think then for me, it's epi and continuing the whole bowel irrigation, right? I'd probably give another dose of activated charcoal. There's little downside to giving more activated charcoal to hopefully bind it up, because if he's getting sicker, that means he's absorbing it from his gut. It's not that it's like, oh, it's circulating and all of a sudden it starts working. If he's getting sicker, that means there's ongoing dissolution and absorption from his gut. So that means you got to try the best you can to either get it out or to absorb it, right, with charcoal. Now, Colin saw that they vomited it up, and we talked about like lavage is out, really, except for really maybe a handful of things I would say that are going to be uniformly fatal. But the fact that you saw tablets doesn't mean we should start inducing vomiting in people and stuff. But I agree that I think it probably was helpful, particularly the sustained release. If they're still intact, that's less drug, right? And so ultimately it might have worked as an advantage, right? The emetic properties of glucagon, but we don't want to induce vomiting, right, in these people. But I think that's really it. And then the high dose insulin, if you can get it, right? High dose insulin usually works better for beta blockers, is my anecdotal experience in calcium channel blockers, and that's really more at the receptor where they work, right? Beta blockers are working at a receptor, where calcium channel blockers are blocking all calcium movement. So that's generally why they're much sicker, but the approach is going to be the same. So I think that everything that's being done is fine here. Atropine, why not? But atropine really doesn't work. And then if you want to talk about, lining them up for maybe putting a transvenous pacer in, that's fine, particularly if you're at a big institution, but if you were thinking, hey, I have to transfer this person, I would probably try to get a transvenous pacer in, knowing that even if you get captured, there's no squeeze. There's no inotropy to that heart. So just because you get captured, don't think, oh, hey, things are shaping up. What it is good if he goes into complete heart block, right? At least maybe you can then take over the rhythm and start pacing them in conjunction with your other meds.
So I was going to ask that question to Colin, is with this specific patient, is pacing something you guys attempted? And if you did, was it successful?
We did not attempt it, and I totally agree. The atropine was just like, why not, sort of thing.
Right.
I pretty much knew that wasn't going to do anything, and we didn't end up needing to pace him because he did respond, and his heart rate started coming up again. It was definitely in the discussion, and the kit was there, and we had talked to cardiology about coming down to help. But generally speaking, I mean, it's our procedure. In most of the cases. And I think because his deterioration was luckily in a little bit slower motion than I have seen with these things in the past, I think we didn't quite get to that level.
Okay. So what I want to do here is, Dr. Moody, you have been very patient, and you have not really have been able to say a whole lot just recently. I want to bring you in, and we can do this part pretty quickly because there's some other parts of this story and what happens with this patient, what we do with him. But let me ask you, do you call poison control on all of your poisoned patients? And then specifically in this specific situation, when do you call poison control?
So first of all, I just want to say to Colin, oh my gosh, this is an amazing case, and you managed this like a champ.
Right.
And as I was reading it, I was kind of getting palpitations myself. I'm like, okay, I want to do all these things at the same time. Remember how on the board exams, which one do you do first? I was thinking about the coordination and how you possibly managed all that. But to answer your question, Mike, definitely yes. Right from the beginning with this patient, I want to gather at least 3 nurses. I want one on the phone with poison control because I want to be at the bedside, and I want somebody to bring me one of those cute little Vocera phones because I want the pharmacist in my ear, and I want to be telling him, okay, here's what him or her, I want to be saying, this is weird orders that you're about to see, and here's why, and here's what I need. I'm going to need high dose this and high dose that, and intralipid, and please find me what I need. And so I want the pharmacist on the phone, but I don't want to leave the bedside because I want to be there with the other nurse. And then the third nurse, I want on the phone with the toxicologist. So yes, all of the above, all at the same time, but coordinating it as quickly as I can. So Colin, wow, amazing.
So Dr. Akpan, quick question for you on this. Do you ever, as a psychiatrist, have an opportunity to call poison control, or is that something you just leave to the folks in the emergency department?
Yeah, like I said, I'm still pretty early on in my training, but based on what I've been able to see, a lot of the emergency room docs, definitely take that step forward in contacting poison control. But if something were to kind of go through the cracks, again, that's where we can kind of step in and make that call because it's a team effort.
Yeah, and even sometimes poison control might say, hey, look, you don't need to do anything. That thing, like, for example, rat poison, which is like literally you need to eat like a bucket of it, right? But you know, don't worry about it, right? So still there could be an opportunity to have some benefit from that, even if you're not in a critical care setting. So there's 2 questions on glucagon. Sean, I'm just going to bring those to you real quick here. So the first one is, why is it not available in hospitals? And the second is, how do you balance the fact that it does cause vomiting with the potential benefit and again, the potential detriment from the vomiting. So pretty quickly to answer both of those, and we'll sort of move on forward here. But I just want to make sure folks in the chat that had questions, we get those answered.
Sure, I'll be real quick. So it's just like every other drug shortage, right? And it's not a big money maker. So it's just not being manufactured. So that's the reason why it's no longer available. And it's available, but it's just not the emergency where we used to send somebody with insulin requiring diabetes, where a family member can give an IM injection, right? So this is actually potentially dangerous for those patients as a whole. It's interesting that this patient did vomit so much, because I've used so much glucagon in my career for this and calcium channel blockers, and they don't vomit as often as you think. And it's not a reason to not give it. But I call this really kitchen sink and bathroom tub and everything. Calcium channel blockers, bad beta blockers like this, a large sustained release, you just throw everything at them, right? And often you don't know why they live, right? But they do. And so it's probably a collection of everything, but I would give glucagon. But if I had to choose between glucagon and an epinephrine drip, I'm going with the epinephrine drip.
Got it.
To be honest.
I actually have a question. There was a paper a number of years ago, many years ago, out of Cincinnati that looked at milrinone or amrinone at the time. Is that useful at all?
Not really, no. So they've looked at those phosphodiesterase inhibitors, right, for these indications, and they really have. Now, if they were like, am I going to let them die without trying it? No, but it wouldn't be definitely something I would be recommending. It would be so far down the line that I would, but it would be, if nothing else was working, I would do that, and I would do so that's. But you're right that had been looked at, but really didn't pan out.
So let's move ahead just to make sure that we get all of this in. And David, thank you for your comment about the wish you had some of these resources at the Critical Access Hospital. And I sort of want to sort of correlate that with something that Dr. Moody just talked about with the poison control, because you think to yourself, oh, I don't really need to know anything about toxicology. I could just call poison control. But in the end, poison control is a person on the phone that's giving a recommendation, and then it's up to us to not only give those medications, but give them in a timely manner to make sure we have the medicines that are at our hospital or are soon to arrive at our hospital to give in a timely manner, and then to assess response to those and see if we need to give more. So really, this discussion is like so important when these type of patients come in. It's not a common thing with this beta blocker overdose, but man, when that happens, having this baseline knowledge is super important. So what happens with this specific patient? Becomes bradycardic, gets atropine a couple of times, really not significant improvement. He gets more hypotensive. It's going down to 68. It doesn't have a whole lot lower to go, right? Decreased level of consciousness, 5 milligram bolus of glucagon, then at 5 an hour. So there's enough of that. And then the 3 grams of calcium gluconate, I think, if I'm reading this right, was given again. He has the epinephrine infusion started. Sean, you talked about that. Blood pressure went up to 95 systolic, and his heart rate went up to 56. And all right, so we're going to skip that part about the poison control center there. But let's go to decision point C here. So I like to sort of think, and I know, I believe it was, Stuart Swadron who sort of said that you need to know what you know, and then, 2 steps past that, right? And so I always like to sort of go to those next couple steps and see what we would do. So, we've done a lot of things, right? But the patient just isn't really getting any better despite everything we've thrown at them. So where do we go from here? Because there is a specific thing that you ended up doing, Colin, and I wanted to make sure that we have time enough to discuss it. So Sean and then Colin, blood pressure's low, you're concerned about the patient actually arresting. Where do we go next?
So I know that Colin gave intralipid, or what we call intravenous fat emulsion, right? Is probably the more correct name. And I don't fault him for it. He's at the bedside, right? This is really a pericode medication. We just have to be very disciplined, because particularly in toxicology, it's the last thing that people give, and person lives and they said, oh, that's what worked. So we don't know. He's doing a lot of stuff. They're doing a lot of great critical care medicine, keeping this person alive. I probably would have given them intravenous lipid emulsion too. I mean, if I'm there and I'm like, hey, this person's going to code, but that's really what it is. It's a peri-code medication. It's not right, and so it really works best for local anesthetic toxicity. But if you had a drug that might be favorable for it, propranolol is very lipophilic. And so I won't get into all the ways that we think it works, because it works like 4 different ways. But one of it is it's a lipid sink. And with lipid-filled medications, not only does it form basically like a mycel, but it might even pull it off of the cardiac myocytes and other tissues to trap it. And then it provides the substrate for the damaged, pharmacologically damaged, not physically damaged heart. And so there's a lot of benefit to giving it, I think, in this patient. But I just want everybody not to be reaching for intravenous lipid emulsion, because this person absolutely, I know someone put in the comment something about ECMO. Intravenous lipid emulsion absolutely can screw up your ability to effectively do ECMO. And so we don't want to just throw it at all these poisons and then not be able to use ECMO that might be where this, particularly if it was a calcium channel blocker poisoning. But that being said, Colin, I fully support you with giving, and the person survived, right? So maybe it was the thing that tipped it, but maybe it was the combination of everything.
How about dialysis, Sean? And then Colin, I want to hear your thought on the backstory, the colorful part of the story, with how you decided to give the fat emulsion, and if you actually had that available and how long it took to do. But just briefly, Sean, dialysis.
Yeah, so dialysis, I have been a toxicologist for a long time, longer than I've been a physician. I was a PharmD toxicologist before I was a physician. I have never once, ever, even on Poison Center, when I was Poison Center director, on the phones, ever dialyze a beta blocker. Why? Because the atenolols don't get that sick. They just don't get sick, right? It's very water soluble, and that's probably a function of its physical chemical properties. It's not very water soluble, so it doesn't do a lot of damage to the cardiac myocytes. It doesn't get into the tissues. They don't stay sick for a long time. And even if they were, they're going to be too hypotensive to dialyze. So it's one of these kind of things that we always talk about. Oh, well, these are dialyzable beta blockers. If they were that sick, even if it was atenolol, they're not going to be able to tolerate dialysis, more likely than not. But generally, those ones that are dialyzable just don't get that sick. And all the other stuff that we were doing already, they usually respond very well to those medications rather than having to go. That being said, again, if I thought someone was going to die from an atenolol poisoning and I could just keep doing push dose pressors to get them on the machine, I would do it, right? I'm not going to let them die, but I don't want people to really think of this, any beta blocker poisoning, including atenolol, acebutolol, as a dialyzable poisoning.
So I'll tell you what we're going to do. Colin, if you could give us some additional information on that, the backstory with all that. And I mean, unbelievable, like 55 minutes have gone by so fast. So what we'll do is, if you could spend about 2 minutes doing that, we'll have about 30 seconds, 45 seconds for each of the panelists to give their thoughts on some takeaway points with all of this. And we'll start with Dr. Akpan, then we'll do Moody, Kaide, and Nordt. So Colin, take it away, backstory with what happened with this patient.
Well, as this guy got progressively sicker, and although he did respond a little bit to what we were doing, we were thinking down the line, where is this going to end up going? And the Poison Center was having a little trouble contacting their toxicologist.
Mm-hmm.
So I was working off the information from the Poison Center, and I knew what to do for this case, but when it came down to the decision making on, is intralipid a good idea? I know it's a possibility. I ended up going around the system a little bit and texting one of our former fellows who was a toxicologist in our region, and I kind of went through the back channel and we talked about it, and they basically said, I don't think there's a huge downside in this particular individual to doing this. And continue to try to get your insulin going in addition, because that's like the one thing you haven't gotten in there. And they said, well, I think it's not a bad idea. And our pharmacist jumped on it right away, the second pharmacist, and that's kind of how that got started. And it's interesting at OSU now we have a new toxicologist who's practices as mostly as an emergency physician, but he is another encyclopedia like Sean is of toxicology, and he said 24/7 you call me if you have a question, and I've taken him up on that many times, and he's very very useful in these situations because he's like I said, the encyclopedic edition of a toxicologist. But it turned out that this patient did well, and it was a little tense for a while.
Yeah, yeah, it certainly sounds like it, and I think all of us have memories. Charles Worlow is on the call here, and I know you've been practicing a long time. I mean, all of us collectively have been practicing over 100 years, right? And man, we've all had those times we remember where people, despite everything we're doing that we can, continue to get worse, and it's a super scary time with that. And we want to just try to think of anything else that can be done. So, Colin, really congratulations as far as doing a great
Thanks.
job with this patient. I mean, certainly without the care, or if he waited in the waiting room for an hour because you didn't believe him, I mean, certainly this could have ended in a very different way. So, Dr. Akpan, why don't we start with you? 30 seconds, some things that you've taken away from this discussion. Certainly doesn't have to be emergency medicine, but could be any points, probably just one big point from you.
Sure. Well, as a resident, this is such a wealth of knowledge. So thank you for letting me be on this esteemed panel. I think the major thing that I got was, we have to be able to triage the importance of what we're seeing, whether it's that medical stabilization in a suicidal patient, and then taking those next steps and looking at risk assessment and things like suicide crisis syndrome, or the interqual criteria for admission, that can really help the patient in their longitudinal healing.
Excellent. Dr. Moody, takeaway points.
Yeah, so I think we just have to believe our patients. We get so burnt out sometimes with having so many patients who come in that lie to us. And so I think we truly have to believe the patient. If they come in and they say they took 40 pills, whether we believe them or not, we just have to act on it and treat them as if that is true. Whether it's true or not, we have to just start on it. And my next step is to go and talk to my pharmacist about the what doses do I have of these medications, because I didn't realize some of the things that Sean talked about of how the shortages are. So I want to talk to my pharmacist and just see what I have on hand.
Colin, big takeaway point you'd like the listeners and the folks who have joined us and given us an hour of their time to take away from tonight?
Sure. I have two. The first one is don't underestimate the power of certain toxins and poisonings to be very, very devastating. And I'd say this is very high on my list of worrisome things. The other thing, and I think the most practical thing to take away from this is when you have a plan and you know what your plan is, make sure you get that plan initiated and get the right people on board. And if you have to go around somebody who's in the way, this is the time to do that. And you don't like to step on people. You never like to do that, but you sometimes have to step over something that is slowing down the process and really take it very seriously, or else you really can't get the resuscitation done in a timely fashion.
Excellent. Sean, what would you like folks to take away from tonight?
So thank you again for having me, and it's so great seeing everybody. So two things is I would recommend you call the Poison Center every time, even if it's very straightforward. And the reason why, as a former Poison Center director, the only way we keep our doors open is by phone call numbers. When we go to the state or something, and if the numbers go down over time, the funding gets cut. So I always say to people, even if you don't think you need the Poison Center, call them, because when you do need them, they will be there, right? So that's one thing. And it's just good to get on the chart and all that other stuff. Even I call them, even though I say, hey, look, I've got it, but I just want to help them with the numbers and stuff like that. The other thing, and you already heard it from everybody, but as emergency physicians, there are a few poisonings that can get sick really quick. So Colin mentioned cyclic antidepressants, which we really don't see that much anymore, but citalopram, which we see a lot as an SSRI that acts just like amitriptyline, right? Cocaine poisoning. So there's a lot of sodium channel blockade effects. So that's why I really try to shy away from the cyclic antidepressant name. The other thing is, and as you heard, you want to be at the bedside, right? These people get super sick quick. And if you even have to say, at Loma Linda, I'm fortunate that we always have 24 hours a day, at least double coverage. So I can say to one of my other attendings, hey, can you just keep an eye on my other patients because I'm going to be in for a while? And they'll do that with me. If you're solo coverage, you can't do that. But sometimes, like your charge nurse, you just say, you know what, I've got to be in here, or we got to move this person right in front of where you're a doc box or where you sit, just so, hey, you can keep an eye on them, even if you're running around putting out fires and things like that. Thanks again for having me, Mike, and it's so great being part of this.
Well, thank
This
you
is always-
so
this is
much.
always
Not
fun.
only, yeah, absolutely. So thank you so much, not only to our panelists who have said their expertise, but obviously there's a lot of expertise just on the call with all the folks who have joined. So thank you so much for your comments in the chat and for being here and taking an hour of your time. I hope we were true to it. For the next book club is on Monday, December 4th. This is a 32-year-old male with a heroin overdose. And the easiest way is just to go onto the website, the EM, Emergency Medicine, Bouncebacks.com website. You can also scan this QR code. And again, I hope everyone has a good rest of their night, and we will see you at the beginning of December. Thanks again, everybody.
Thanks.